earlier we broke up into smaller groups. So this was really intended to solidify what our thoughts are about the research that we just it was just recently presented to us, and also to shape what are the questions that we really need to ask as we go and there's more research that's going to be presented to us. What are the critical points that we really need to raise, and also for tomorrow as we start seeing all of this, all the process in which the new information is being implemented in the country, and also when we're trying to improve future research, what are the questions that we really need to ask for that. So we will start with reporting back on what's been discussed in the smaller groups. I'll give maybe only 2 minutes for each person to reply, or 3 minutes to respond, to report back. And afterwards, when we have time, if there's any other lingering thoughts, we can share that to the floor. So the first one I want to call Dr. Francis Mwansa from the red team.
Thank you very much. I think I'll stick to the 2 minutes, but there were 2 red teams, so you have to identify us as the left-right team. So the first question was what we learned, or what rather surprised us this morning. A few thoughts. I think we were unanimous in agreeing that much of the information presented was difficult to understand. We also agreed to the fact that the interpretation of the results that we saw really need to be made with the local context in mind. There was also a thought that there is need to show how to translate. There's really need to show from what we had early in the morning, simpler ways of presenting this information to the policymakers that we felt didn't come out so much. So that surprised us. The fourth thing that surprised us, not really surprising us per se, something that we learned was that much of what was presented is stuff that I think coming from the countries, especially where this was done, something that we knew but had more or less no evidence for. So the results are more or less a validation of something that we knew, and therefore they form more or less a reference point. The second question was looking at the strength of the data and also the limitations. Some of the strengths that we pinpointed were that the results shared in some way do force linkages with the financial aspects of the program, more or less like raising awareness of the complete continuum of running the program. We more or less do concentrate so much on the program. So it's a strength that it has brought that awareness to us. The second aspect is that it highlights how much of the cost of running the program is distributed across the different cost drivers. The third strength that the results showed us was that, like I mentioned, which was also a lesson that we learned, was that it forms quite a good baseline for similar future exercises. Then lastly, as a strength, we realized that Whereas the countries that were picked are not probably exactly the full representation of the global picture. They more or less form the mean countries. They are not on either extreme, they are more or less in the middle. So it's a strength in the sense that some of the aspects of what was presented can be extended to the countries that were not part of the studies. Amongst the limitations, we also noted the fact that it's really hard to draw, whereas that is a strength, but it's still hard to draw conclusions that are very particular and specific to the countries that were not in the studies. The second limitation is the fact that global policy may be hard to make from the pool of 6 countries that were picked. The other limitation was the fact that most of the studies took a very immunization specific lens, and instead possibly they could have taken the full primary health care approach. Lastly, the question on the lessons learned and the policy implications. A number of thoughts. The first was that we learned that the human resource contribution is quite huge. In terms of the policy implication, is how we have to approach this human resource component versus the primary health care continuum that it shares with. The second lesson was that what was realized was that people often did not know the full cost of running an immunization program in most of these countries. And as a lesson, it served the purpose of highlighting to people every component that is actually involved. Looking at the policy implication, it was thought that the most of the rate planning that we do, particularly at the facility level, does not actually include some of the aspects that are highlighted in the studies that we had in the morning, particularly the issue of the human resource cost, the salaries, and so on and so forth. So if that possibly could be part of the micro planning, so that it gives the full picture, that would be good. We also thought that there's need for immunization as a program to look at the costs from the primary health care perspective, in view of the fact that much of what the program does has an aspect of integration, and so the approach has to also consider other aspects, because it's not completely delinked from the rest of the primary healthcare aspects. And lastly, it sounded more like a caution that the interpretation, rather the naive interpretation of the results, especially those that we had in the morning, might not be very appropriate. Thank you very much.
The next person, also from the red team, Jessica. You can also leave.
Thank you. So I'll be very brief because most of what we discussed, Dr. Mwansa has already presented. So good to know that the red teams are talking about the same things. So in terms of what we learned, to add, I would say that we discussed how a lot of what was presented in EPIC 2 really sort of confirmed or validated what we had already suspected or knew from a practical level, or what we had learned from EPIC 1. So it was really sort of a confirmation of what we had already thought was the case. In terms of the strengths, obviously a lot of robust analysis was done. From the country viewpoint, I would say it becomes more difficult to digest and really translate into action, and how this information can really be used for decision making and planning purposes. So our discussion really focused around how can this information be rolled into some of the broader planning purposes, investment planning, budgeting exercises, et cetera, both for immunization but also for the larger health context. And then in terms of lessons learned and policy implications, well, even beyond that, one of the things that we talked a lot about is how this information can be extrapolated both within the countries where the information was collected and presented, but also in other countries. So I know Dr. Mwansa talked about this as well, and even in countries where the region is not even represented. So in some of our Asian country contexts, what can we learn from this, and how can it be used in those settings? I think I got everything. Yeah, thanks.
Next is from the yellow team. It's just like a game. Yellow team, we have Diane Coraggio.
My first lesson learned was don't smile at the group organizer or they'll make you the group leader. So group members, feel free to contribute, but we kind of danced around a little bit. So I tried to group them into a couple of different categories. So things that we thought were surprising/interesting. We talked about the important variations between countries and within countries. And then we talked about where those were attributed, differences in salaries and labor costs. Costs of routine immunization were higher than we originally thought. And then along the theme of surprise, one of the group members made an interesting point about the efficiency curve, and we talked a little bit about whether or not countries would be surprised by which facilities were the outliers on that curve. And so if countries could identify which facility maybe was one of the more inefficient facilities, and could that be useful for advocacy efforts? So that kind of covers surprising and interesting. Limitations, there was some conversation about maybe we had a missed opportunity to gather more qualitative info from countries. So while we were pooling the data and standardizing determinants, maybe some of the country-specific details were lost in doing that. And it might be a good idea to, in the future, kind of go back to the countries and talk to them about how they feel about the data and whether or not they think that it accurately reflects the situation. Some policy implications. Planning and budgeting was a big one, so awareness around variation in unit costs and differences in unit costs, so it could be rural versus urban, and how countries do the timing of their vaccination programs. And so this was particularly relevant in Zambia, where sounds like there's a big debate about immunization weeks within the routine immunization program. Resource allocation and the integration of health areas across the health system. So rather than looking at vertical programs, if we could integrate immunization into antenatal care, maternal child health, that kind of thing. And this kind of goes into policy implications, but also moving forward, looking at the future. This might encourage countries to do more country-specific analyses for country consumption. And then things to think about moving forward. So in thinking about new introductions, we also need to think about the sustainability of new vaccines and country capacity and ability to pay for co-financing. So that kind of touches on Logan's presentation from earlier. And then along with integrating this into other health areas, we might want to think about looking at other outputs aside from just DTP3 coverage. And I think that's all we have.
Next person would be Meghan O'Connell.
Great, thanks. So speaking on behalf of Yellow Team 2, a few of the things that we talked about were firstly what we've learned and where we've come since EPIC 1 and EPIC 2. Ultimately, before these studies took place, immunization was shown as a unit cost, and we now have a function to predict costs utilizing multiple variables and to predict costs on a spectrum. So moving from a unit cost to a function to predict costs has allowed us to use a map and use that map to look for gaps and utilize the function to get a bit deeper. In terms of policy implications, there was a question on coverage estimates and what's really going on with coverage. There are a lot of instances where coverage is over 100%, and it's a problem with planning at the facility level. I think there's a deeper question on whether this is migration, inflation. Is it over-reporting, or do people working at the facilities just not know? And the point came that this is a big point for policymakers and an area to investigate a bit deeper. A second policy implication that came up is the limitation of current financial systems and their ability to collect the type of data that we need in terms of data at the activity level, and the amount of effort needed to go beyond financial tracking systems such as the system of health accounts. The EPIC study was the first example, or the largest example, of using the system of health accounts to disaggregate this data more, and I think we've seen that it's not always replicable across countries, and that it's a really large effort. In terms of things that our group wanted to know, we'd really like to see a costing study done alongside a coverage study. I think we've seen an extremely convincing presentation of economies of scale, but there was a call to use a gold standard biometric tests, such as a blood test, to correlate the presence of antigens in the population with outreach efforts, and to really bring those two pieces of data together. Also wanted to know about efficiency and how it relates to variation in costs. Which component of the resources can you either cut or reallocate in order to improve efficiency? Is it labor costs or is it vaccine costs? And there was a call to do a bit more investigation there. In terms of what surprised some of the group members, there's a bit of surprise that there was no results presented on scale-up costs, and a wish that even bad data might have been worth presenting to get the benefits of that critique. And also a pleasant surprise or reaction from the pooled analysis approach that was used, but an indication that it brought up two greater issues. One, that it would have been great to see that information disaggregated from the vaccine costs disaggregated, and also that it leads towards a natural tendency to compare across countries, but ultimately it's not a safe comparison to do. Lastly, another call to see cost per dose of outreach compared to cost per dose at the facility, and a question on whether or not these outreach costs were intentionally excluded from the EPIC study, and if so, was this a weakness or a limitation in the study? Thanks.
Thank you. The last team is the green team. The first one is Zach.
So what was interesting or surprising, the general consensus was that there wasn't that much that was really surprising that came out. These results were sort of what people had intuitively thought was going on. But taking a step back, I guess it was surprising that we actually don't have data to show increasing marginal cost for the last mile. And so this is an intuitive concept that we believe, but that we don't actually have the empirical data to show this. And so some discussion of whether looking at facility level costs is the right approach for looking at increasing marginal costs in the aggregate. So facilities could be saturated and have pretty constant marginal costs, but then you add in other activities at other levels like campaigns. And so you could see increasing marginal costs in aggregate, but not at the facility levels individually. Some surprise, a little bit of surprise at significant variation within countries. And so this raised the question of, can we say anything meaningful for program management and planning looking at these results within countries? And that was not clear. Some limitations. One was the lumping of labor costs into a broader category, so including salary and per diems, and so some talk of whether we could disaggregate those further. Coverage was raised as probably the largest limitation, and some questions raised as to, it would be useful to know, but what's the actual value of getting this data compared to the cost of obtaining it? So it's a big question. We could spend a lot, we could do a good job getting it, but it would probably be really expensive to actually get a good handle on that data. The sustainability of costing studies like this, really you'd want to have routine costing going on, so we thought, would it be possible to identify a subset of indicators that explain 90-95% of variation or the total costs that are going on that could be routinely collected? You'd still need to set up a system to actually routinely collect those costs from facilities, but it could help alleviate a lot of the burden of all the data collection that was done in these larger studies. So some policy implications. Question was asked, how does this costing work help with planning for Gavi transitions, especially? And one issue is the economic costing perspective versus a budgeting perspective. So a lot of care was done to take into account opportunity costs. A lot of shared costs were taken into account, but it's not clear exactly how to translate those back into budgetary costs. And so trying to figure out how to crosswalk between the different values that are of interest to different stakeholders.
And the last one from Green Team, George goes back to.
What a big surprise. You would do it better than I. So please, can we change the presenter so please. Thank you.
All right, well, yeah. So we talked a lot about the same things as the last group, and I think our feedback fell into two major categories. One was feedback about the methods and the methodology itself, which included some about incorporating contextual factors from the country and the quality of the sampling and those sort of areas. And then I think the second was just the policy implications, basically, and that was the concern of misinterpretation and going to politicians and how one point that struck me was this idea that once you give policymakers a message, then you can't really take that back once they've made a decision with that data. And so just the importance of having a clear, definitive takeaway point for them that's also accurate, and then delivering that. So that was one area, but also, we also talked about the usefulness of this, that people were mentioning how this is already proven useful in their countries, like in Honduras, I think it was mentioned, as the Gavi transition happens with more country-specific financing compared to donor financing. So they said it's been a useful tool to advocate for immunization programs and to prove that immunization is not just a silo, that it's the costing applies to multiple programs. So yeah, so I think a lot of the stuff we said has already been mentioned, but I think that was the general point. Were there any other points from our group you wanted to bring in? Yeah, that was it.